Part 1 demonstrated the initial actions to be taken in a first aid incident. It demonstrated the first aid that all seafarers need to understand, how to manage a situation, and the actions to take to potentially save a life. In Part 2, we look at a variety of major and minor injuries and illnesses that seafarers also need to know about. Some first aid situations will need immediate actions. Officers or those on board ship who have completed additional first aid and medical training will carry out continuing first aid. The first aider then becomes an assistant in the situation and follows instructions. In some instances, action may not be taken until radio medical advice has been sought. In all the examples, the first aider will always carry out DRABC: danger, response, airway, breathing, and circulation CPR. They will also assess the scene to establish what has happened and ensure it is safe. Assess the casualty, then treat and monitor them, remembering to treat for any shock. In all situations, the airway always takes priority. For additional information, use the accompanying workbook. The musculoskeletal system comprises bones, tendons, ligaments, and muscles. The skeleton provides the framework for the body and gives some protection to internal organs. Muscles move the skeleton. They are attached to each other or to the bones by tendons. Ligaments bind bone ends together in joints and support internal organs. A broken bone is known as a fracture or a break. Although the outside of a bone is hard, it may crack or break if struck, twisted, or overstressed. Fractures can be caused by indirect trauma such as falling on an outstretched arm, muscle action, a twisting or wrenching movement, disease that causes the bones to be more fragile, or by direct impact, for example, an object hitting someone's leg. There are 3 types of fracture. In a closed fracture, the skin surface around the damaged bone is not broken. In an open fracture, the broken bone has penetrated the surrounding skin. This type is more serious because of the additional problems of bleeding and exposed bone with high risk of infection. A complicated fracture is where there is an associated injury, such as damage to an internal organ or an important blood vessel. Any of these types of fracture may be stable, with bone ends not moving, or unstable, where the ends of the broken bone may move. There are a number of features that will help in diagnosing a fracture. There may be pain at the site of injury as well as tenderness, bruising, redness, or even visible bone. There may be a lump or other deformity, which could include shortening of a limb. There may be loss of movement or power. Fracture management includes immobilization. This reduces the pain, prevents further injury from bone movement, and makes moving the casualty easier. In an open fracture, control of bleeding and wound management will also be necessary. The injury should be monitored, including blood circulation distant from the injury. If the bone is protruding, the management of bleeding is the same as for a wound with a penetrating object. To stop bleeding, put pressure on the wound at the base of the protruding bone. Never put any pressure on the bone itself or attempt to push it back into place. Dressing should be built up around the bone and secured. A sterile, non-fluffy dressing should be placed lightly over the bone, but it should be labelled to make it clear that it covers exposed bone. This reduces the chance of pressure being placed on it by mistake. The injured limb needs to be monitored by checking the circulation below the level of the fracture. Is the limb warm and a good colour? Is a good pulse present? Is there any nerve damage? Is the casualty complaining of loss of sensation, numbness or tingling? After the wound has been dressed, the next stage is to immobilize that part of the body which has been affected. There are a number of immobilization methods available: supporting with a pillow, using slings and bandages, or using a splint, as in this case. The person in charge will decide the best form of immobilization to be used according to the injury, whether evacuation is imminent or how the casualty is to be moved. Splints should only be used by someone who has been trained in their use, as harm may be done if they're not used properly. There is time when managing a fracture to consider the options available and whether the casualty needs pain relief before immobilization and moving. A fractured leg may be secured to the non-injured limb using triangular bandages, as in this case. To do this, place padding between ankles and knees, as well as in the gaps between the legs. Line up in position the triangular bandages before applying and securing. The foot should be tied first using a figure-of-8 method. All knots should be placed on the side opposite the injury and loose ends secured in place. The sequence of ties is joint below and joint above, then immediately above and below the fracture site. The natural hollows at ankle and knee should be used to place bandages, which are then slid up or down into position on the leg. The injured leg is never raised, as it is not supported under the fracture. Further information can be found in the accompanying workbook. A high or elevation sling is used for injury to the collarbone or ribs. It is also used when elevation of the hand is required to reduce swelling, as in burns to the hand, or to prevent movement as part of bleeding control. Tie a knot at the elbow point. Then place the triangular bandage over the front of the elevated arm, with the long edge down the body and the point of the triangle to the elbow. Place the sling over the arm and tuck fabric under the fingers and arm while holding the elbow knot in place. The elbow is automatically supported as the sling is tightened. The fabric is taken around the back of the casualty and the end points tied together. The finished sling should support the elbow, prevent the arm from slipping out under the sling, and allow access to the fingers to check circulation. Further information can be found in the accompanying workbook. A low or broad sling may be used for an injury to the lower arm, upper arm, ribs, elbow or shoulder. Place the triangular bandage under the arm with the elbow at 90 degrees, the long edge down the body and the point of the triangle to the elbow. Lift up the lower point and take up around the neck to tie with the upper point at the neck. The arm should be fully supported from elbow to fingertips and not droop. The finger should be accessible to check circulation. Further information can be found in the accompanying workbook. A dislocation is a joint injury in which the bones are partially or completely pulled out of position. It can be caused by direct impact or muscle contraction. The signs and symptoms are similar to a fracture. There may be pain, swelling, bruising or deformity. There will be loss of movement and loss of power of the affected limb. As with fractures, the immediate aim should be to immobilize the limb. Broad fold bandages are used for this type of injury as well as elbow injuries. The idea is to splint the arm to the body when injury prevents the use of a low sling. Take care of any associated wound, monitor the circulation, and treat the casualty for shock. Torn ligaments may be associated with a dislocation. The consequences of a dislocation can be severe, even resulting in paralysis if major nerves are involved. No attempt should be made to relocate the dislocation. Further information can be found in the accompanying workbook. In this section, we have shown general first aid for fractures and other injuries relating to limbs. Full first aid details of these and other types of fracture can be found in the accompanying workbook. If there is any part of this section you do not understand, please revisit the relevant information, and when you are confident you understand, move to the next section. Sprains and strains are injuries to the soft tissues surrounding bones and joints caused by overstretching or sudden violent movement. A strain involves muscles and tendons. Tendons are strong but inelastic fibrous cords joining muscle to bone or muscle to muscle. A sprain involves ligaments, which are tough, fibrous, partially elastic tissue. They bind bone ends together in joints and also support internal organs. Sprains and strains result in restriction of movement, swelling, bruising, and pain. It can be difficult sometimes to tell if an ankle is sprained or broken. For simple sprains and strains, the management can be remembered by using the word RICE. R is for rest, I is for ice, C is for compression, and E is for elevation. All help to reduce swelling and pain. The casualty does not have to be confined to bed, but the limb should be rested. An ice pack may be applied, but it should always be fabric covered and never left in place for longer than 10 minutes in every hour. A bag of frozen peas will work just as well. A compression bandage should not be applied until the foot can be placed comfortably at a 90-degree angle to the leg. When in position, it should be placed to reach from the base of the toes to the knee, that is, from joint below to joint above the injury. An elastic crepe support bandage is best. Make sure the bandage is not too tight by checking the circulation and sensation to the toes. With a sprained wrist, watches and jewellery should be removed from the injured limb before swelling becomes too severe. Then a compression bandage should be applied from the knuckles at the base of the fingers up to the elbow to give full support. Check the bandage is not too tight by monitoring the circulation and sensation in the fingers. Then support it in a high or elevated sling to reduce the swelling. In this section, we have shown how to deal with soft tissue injuries which are relatively common, and treatment should be carried out using RICE, rest, ice, compression, and elevation to reduce swelling and to aid in recovery. If there is any part of this section you do not understand, please revisit the relevant information, and when you are confident you understand, move to the next section. More information can be found in the accompanying workbook. Injuries involving the spine are serious. When a spinal injury occurs on board ship, it needs time and manpower to be coordinated and handled correctly. Management of a suspected spinal casualty should never be rushed, as it may result in serious consequences. The most important indicator of spinal injury is what is known as the mechanism of injury. This is the way in which the injury occurred. It may be caused by abnormal force on the back or neck, or by violent twisting and bending. A blow to the top of the head may result in an injury to the cervical spine. If a casualty has fallen from a height, a spinal injury should always be suspected. The most vulnerable areas are the neck, known as the cervical spine, and the lower back, known as the lumbar spine. The injury may involve bones, discs, muscles, and ligaments. The most serious injury is when damage is done to the spinal cord and nerves. This is because the spinal cord is the pathway for messages between the brain and the rest of the body. A neck injury can result in a casualty not being able to breathe. Damage may be temporary or permanent. If the cord is severed, the result will be paralysis or even death. If any of the following signs or symptoms are present, spinal injury may be indicated. Pain, either at the spine or elsewhere. Tenderness and bruising over the spine. The casualty is lying at an odd angle. There is weakness or loss of control of movement. Change of sensation. Difficulty breathing. Loss of bladder or bowel control. Continuous spontaneous erection in the male. Make sure there is no danger when approaching the casualty. Assess the response of the casualty and the airway and breathing. Remember, if they are talking, they are breathing. It is vital to tell the casualty not to move at all. The alarm should be raised. Only if the casualty is in immediate danger should they be moved at this stage. While waiting for help to arrive, the first aider should keep the casualty still by holding the head in a neutral position and keep checking breathing and level of consciousness. Obvious injury should be noted. The key to managing a spinal casualty is immobilization of the spine and coordinated teamwork.
Now you've just fell from quite a big height.
It is usual for the person holding the head still to control the situation. But it is important for all helpers to follow the instructions of the team leader and not work independently. The person in charge of medical care on board ship will normally be the most experienced person, and they should coordinate the management of the situation as team leader. The casualty should not be moved until radio medical advice has been sought. Immobilizing the casualty on a stretcher or spinal board should be done prior to movement or evacuation. The equipment used and method of movement should be agreed with the evacuation rescuers. In some situations, they may prefer the casualty to be placed on their own spine board or rescue stretcher. Only someone trained to use a cervical collar should fit one on the casualty. It's important to remember that a collar is only an aid to keeping the head and neck immobilized, and that a casualty wearing a collar is still able to move their head. Immobilization of the head by the first aider should still be maintained after a collar is positioned. Only when the head is strapped to a spinal board will the casualty be properly immobilized. To place a casualty onto a spinal board, use the log roll method. Position at least 2 crew members by the side of the casualty. Together, on command, they roll the casualty towards them. The first aider then positions the spinal board against the casualty's back with the bottom edge under the body as far as possible.
Very slowly. Well done. Okay, and again we're going to do exactly the same. Very, very slowly lower her back down again.
On command, the casualty is rolled back slowly against the board and gradually returned to a horizontal position.
Well done.
The 2 crew members then move around to the other side of the board with the first aider. Together and on command, they slide the casualty onto the board to center them.
2, 3.
Then, using the harness supplied with the board, carefully strap the casualty to the board. Place padding between the casualty and the straps. Then the first aider completes the immobilization of the head by placing padding around the head, which is strapped to the board. Then, using all crew members together, lift the board. The casualty will need to be routinely monitored while being prepared for evacuation, paying special attention to their specific injuries. In this section, you will have understood the potentially serious nature of a spinal injury. Causes of injuries to the spine, signs and symptoms, possible sites of injury, spinal cord injuries, and immobilization. If there is any part of this section you do not understand, please revisit the relevant information, and when you are confident you understand, move to the next section. More information can be found in the accompanying workbook. In the case of injuries, the first aider will always manage the scene in accordance with DRABC. Treat any shock and place any unconscious casualty in the recovery position. Observations of breathing, pulse, level of consciousness, pupils and skin will be carried out as part of the general observation undertaken on any casualty. All head injuries are potentially serious and may result in impaired consciousness. The brain will have been shaken inside the skull during the incident and may swell, or bleeding may occur. The skull may be fractured. The result may be mild concussion or the more serious condition of compression. Any casualty receiving a head injury should always be treated with caution and monitored closely. Evidence of a head injury may not be obvious. The symptoms of concussion are dizziness, nausea, loss of memory and headache. There may have been a brief loss of consciousness. If a casualty cannot remember if they were knocked out, then it's likely that they were. The casualty should always have their breathing, pulse, level of consciousness and pupil reactions monitored. If they develop a severe headache or vomiting, their condition may have become more serious. Urgent radiomedical advice will need to be sought. If a casualty has a fractured skull as a result of a head injury, it may be possible to identify a lump or a soft area on the head. No pressure should be placed on a possible fracture of the skull. If the base of the skull is fractured, fluid may leak from the ear or nose. This fluid surrounds the brain and is usually clear, but because it is passing through injured tissues, it may be colored by blood, making it straw-colored or heavily blood-stained. This is evidence of a serious head injury. The first aider should place a sterile dressing over the leaking ear. If the casualty becomes unconscious, they should be placed in the recovery position with their ear nearest to the ground. A head injury casualty should never be laid flat. If they become shocked and are placed in the shock position with legs raised, their head and shoulders should be slightly raised. If a casualty has received a blow to the top of the head from a falling object, or has fallen from a height or sustained a whiplash, then they should also be checked for evidence of injury to the cervical spine. There may also be facial injuries to consider, which may affect the airway and breathing. Compression is a serious, life-threatening condition requiring urgent medical attention. It may appear soon after injury or be delayed, so close observation and monitoring of a casualty with a head injury is vital. Evidence of a head injury may not be obvious. A key feature of compression is a deterioration in the level of consciousness.
Come on, open your eyes.
Pupil size and reactions will be unequal. Breathing is noisy, pulse is strong and slow, and if the casualty is conscious, they will complain of a severe headache. Treatment for this serious condition is only available in a hospital, and it is vital it is recognized early. The first aider may be supporting the person in charge of medical care on board by helping to monitor the casualty. The frequency of these observations will usually be every 10 to 15 minutes, unless indicated otherwise on radio medical advice. The first aider will be able to check pulse strength, regularity and rate, check breathing rate, depth and sound, check pupil size and reaction,
Open your eyes.
check level of consciousness. In addition to these observations, the person in charge of medical care will be monitoring other things like blood pressure. In cases of compression, Urgent evacuation is required. Eye injuries may be the result of foreign bodies in the eye, chemicals and burns, or by direct trauma. The casualty will be in pain and frightened of being permanently blind. The casualty will need constant reassurance while first aid is being carried out. Eye injuries will be managed by the first aider. Care of the casualty will then be passed on to the person in charge of medical care on board, who will seek radio medical advice if necessary. The casualty may be in pain and complaining of vision loss or disturbance. There may be redness and swelling around the eye, which may also be watering. There may be visible wounds. As well as pain, the casualty may complain their eye feels gritty and is light sensitive. The affected eye should be washed out with eye wash solution or tap water immediately. Lay the casualty on the edge of a table or bed with the head slightly tilted over the edge. Place a container below the casualty and wash the affected eye. Washing should always be from the center of the face outwards to prevent contamination of the other eye or further injury to other tissue of the face and neck if a chemical is involved. Wash their open eye for a minimum of 10 minutes and 20 minutes in cases of a chemical splash. The casualty in pain will be reluctant to do this. After washing, an eye pad should be placed over the injured eye. In this section, you will have been shown first aid for specific injuries relating to head and eye injuries. In head injuries, concussion, compression, skull fractures, signs and symptoms, and management. In eye injuries, recognition of the injury, washing the eye and placing a pad over the eye. If there is any part of this section you do not understand, please revisit the relevant information, and when you're confident you understand, move to the next section. The management of these and other specific injuries can be found in the accompanying workbook. When the blood vessels supplying blood to the heart become narrowed or blocked, the supply of oxygen to the heart muscle is affected. This results in pain.
Stuart, you're right.
The casualty may have pain in the chest, radiating to left arm, jaw, upper abdomen or back. They may be having difficulty breathing, be sweating and look pale. Nausea or vomiting may also be present. The first aider should raise the alarm immediately and be prepared to resuscitate if required. Position the casualty supported, sitting up. Loosen clothing at neck and waist to aid breathing. Monitor breathing and pulse closely. If the pain goes when they're at rest, it's most likely to have been caused by angina. When the person responsible for medical care arrives on the scene, they will administer medication to the casualty. Glycerin trinitrate is given as a spray under the tongue. This dilates narrowed arteries in the heart, increasing blood flow. If the pain has been caused by angina, it may subside. If the pain persists, an aspirin may be given to reduce blood clotting. Check that the casualty is not asthmatic or allergic to aspirin. Then tell them to crush one tablet in the mouth and hold it under the tongue. It must not be swallowed. The casualty should be told this is not for pain. Urgent radio medical advice must be sought, and the casualty will be given an injection of morphine for the pain and an anti-sickness injection. Urgent evacuation is required. The casualty should not be left alone and should be monitored closely. A medical emergency may arise in diabetics when their blood sugar levels fall too low.
Carl, you right?
Oh, yeah, go
Yeah?
for it.
Oh.
Yeah.
This is hypoglycemia and is also known as a hypo. This can happen very quickly, and the first aider needs to recognise and manage it before the casualty becomes unconscious. This fall in blood sugar may also happen in non-diabetics, for example, after a seizure or as a result of excess alcohol consumption.
Right. Carl, are you feeling all right?
In a hypo, the behaviour of the casualty changes and may become erratic. Speech can be incoherent and their level of consciousness impaired. The change in behaviour is often mistaken for drunkenness. They may be visibly
You
sweating.
need some sugar.
The treatment is to get sugar into the casualty quickly. If this is not done, they will lose consciousness and become more difficult to treat. Give the casualty a sweetened drink, chocolate bar, sweet biscuits, or even sugar lumps to eat. If the casualty has become too drowsy to swallow safely, smear jam or honey around their gums and inside their cheeks. The sugar will be absorbed into the bloodstream through the tissues in the mouth. If consciousness is returned to normal, the casualty should have something to eat. If the casualty becomes unconscious, they should be placed in the recovery position. Asthma is a common condition affecting breathing. The small tubes in the lungs constrict and become inflamed, preventing air from moving freely. This results in the wheezing that can be heard as the casualty breathes out. It can be frightening for the casualty, who is unable to breathe freely or speak. They may be pale or have a blue tinge to the skin and become increasingly exhausted and distressed with the effort of breathing.
Asthmatic, yeah? Can you just move over there for me?
When treating the casualty, it is important to reassure and calm them. Allow them to sit upright in a comfortable position. This upright position aids breathing. Never lay the casualty down flat. If a known trigger is present, remove it and allow good ventilation of the area. The casualty may have their own medication with them. This medication will be in an inhaler and is known as a reliever because it relieves the symptoms of the attack. Help the casualty take 1 or 2 puffs. It's important to raise the alarm at the start of the attack so the person in charge of medical care on board can attend with medication from the medical locker if the casualty does not have their own. They can also give oxygen. Only the person trained to use medical oxygen should give it to the casualty. Radio-medical advice should always be sought. A casualty suffering from smoke inhalation will have the same symptoms and may be treated in the same way as a casualty having an asthma attack. Seizures are also known as fits or convulsions. They are involuntary contraction of the muscles due to a disturbance in the electrical activity in the brain. A seizure can happen to anyone at any time and can have many causes. Protect the casualty from dangers while they're having a seizure, but never restrain them or attempt to put anything in the mouth. Note the duration of the fit and whether it has involved the whole or only part of the body. Once fitting has stopped, and if the casualty remains unconscious, place them in the recovery position and monitor their breathing and pulse. After recovery from a fit, the casualty will feel exhausted and may wish to sleep. A poison is any substance that, if taken into the body in sufficient quantity, may cause temporary or permanent damage to health, or in some cases death. Poisoning may occur accidentally or intentionally. It is important to recognize possible signs of poisoning so that the first aider does not place themselves in danger.
You sure?
The level of consciousness may be altered. There may be seizures. There may be breathing difficulties or sudden vomiting. There may be visible evidence such as skin burns. There may be visual clues, such as chemicals present. Even the job the casualty was doing at the time of becoming ill or where they were actually working on board ship could give clues as to what poisoning has occurred. The International Maritime Dangerous Goods Code gives specific advice on managing poisoning with regard to antidotes and treatment. These are detailed in the Code Supplement, which contains a medical first aid guide specific for dealing with dangerous cargoes. Any treatment will be managed by the person in charge of medical care on board ship, and radio medical advice should always be sought.
Yeah, I'm with Carl in his cabin. He has taken something via his mouth. He has quite severe sort of like burns and corrosion around his mouth.
The first aider will manage the casualty in accordance with DRABC: danger, response, airway, breathing, and circulation CPR. Position the casualty according to their condition and monitor their pulse, breathing, and level of consciousness. Try to find out what the casualty has been exposed to, when it happened, and the extent of exposure. The accompanying workbook gives more guidance on specific management for types of poisoning. In this section, you will have become familiar with other medical emergencies which may occur on board ship: chest pain, diabetes, seizures, asthma, and poisoning. If there is any part of this section you do not understand, please revisit the relevant information. When you are confident you understand, move to the next section. More information can be found in the accompanying workbook. Being on board ship can expose workers to many different environmental conditions. There can be extreme cold, heat, or humidity. Hypothermia is when the body temperature is 35 degrees Celsius or lower. It can happen after exposure to a cold environment or immersion in cold water. It may also happen as the result of the effect of drugs and alcohol, poor nutrition, and some medical conditions. In the early stages, the casualty will be shivering. This sign disappears as the body temperature falls. The casualty feels cold and miserable. Their skin is pale and cold to touch. Muscle coordination is poor and speech becomes slurred. Behavior becomes more irrational and confused. Pulse and breathing slow down. The casualty may become unconscious and pulse and breathing may not appear to be present. If left unrecognized, the casualty will die. Removal from the cold environment is essential. Rewarming is the first aider's aim and is a slow, passive process. Give the casualty a warm drink and a blanket. If the casualty is conscious, they may be put in a bath of warm water kept at 40 degrees Celsius. If placed in a shower, they should always be sitting on the floor, supported, and never be standing. If the casualty is unconscious, they should be placed in the recovery position and kept warm with blankets. Heat exhaustion is a loss of salt and fluid from the body, which results in the collapse of the circulation. It is caused when there is excessive fluid loss. The primary cause is excessive sweating, although it can be caused by severe diarrhea and vomiting. It is seen in those working in hot and humid climates, especially when they're unaccustomed to the environment. The casualty does not look or feel hot. Their temperature is not raised and their skin is pale. They look shocked. The casualty may feel exhausted but restless, feel faint and dizzy, and may have a headache and muscle cramps. Breathing will be fast and shallow and the pulse fast and weak. Thirst is a late symptom of the dehydration and may not be present initially. Sit the casualty down in a cool place. If they are conscious and able to protect their airway, drinks should be given to replace lost fluid. Drinks should not be gulped, as this may lead to vomiting. The casualty should never be given salt, as it will induce vomiting. Water, fruit juice and isotonic drinks are suitable, but fizzy soda drinks should be avoided. Although the casualty may appear to have recovered, it is important that medical advice is sought and that the casualty does not return to work for at least 24 hours. Hypothermia is when the body temperature is very high. Heat stroke occurs when the body loses its ability to control high temperature by sweating. Its thermostat is broken, and the body temperature can rise to 40 degrees Celsius or greater. It may occur quite quickly and is a life-threatening condition requiring urgent medical advice and treatment. It is often seen when the environmental conditions are hot and humid. The humidity prevents adequate sweating. The casualty looks and feels hot. They are red, but the skin is dry to touch. They may show signs of headache, dizziness and restlessness. The pulse is full and bounding, and breathing is noisy. The condition can develop and progress very quickly, with the casualty soon becoming unconscious. It should be treated quickly and urgent radiomedical advice sought. Death will occur if the condition is not recognized. The casualty should be moved to a cool environment if possible, but if this is not immediately possible, cooling should not be delayed. If the casualty is alert and able to drink, they should be given cool water, but encouraged to sip it so as not to cause vomiting. Ice should never be used to aid cooling, as this may cause tissue damage and cold burns. As well as cooling the casualty quickly, the first aider will be positioning the casualty appropriately and making sure the airway is maintained. They will be monitoring breathing, pulse and consciousness level. Rapid cooling methods are described in the accompanying workbook and will be managed by the person in charge of medical care on board. If the casualty loses consciousness, place them in the recovery position while continuing to cool them. In this section, you will have become familiar with the effects of extreme temperature, hypothermia, heat exhaustion, heat stroke or hypothermia, the causes, management. If there is any part of this section you do not understand, please revisit the relevant information.